Welcome everyone to the Apothecary Tales, the basics of pharmacology. In this video, we're going to talk about the thyroid hormones, its synthesis and release, further what happens when there's a hypersecretion, when there's a deficiency of these hormones, and further its treatment. So let's just get started. The thyroid hormones are secreted by the thyroid glands. It is facilitating the normal growth and maturation by maintaining a level of the metabolism in tissues that is optimal for their normal function. The two major thyroid hormones are the triiodothyronine T3 and the thyroxine T4. The most active form is the T3. Now what happens when there is an inadequate secretion of the thyroid hormone? It leads to hypothyroidism and results in bradycardia, poor resistance to cold, mental and physical slowing. In children, this can cause mental retardation and dwarfism. Whereas the excess secretion, the hypersecretion of the thyroid hormones leads to hyperthyroidism, which can cause tachycardia and cardiac arrhythmias, body wasting, nervousness, tremor and heat intolerance. Now moving on to the thyroid hormone synthesis and secretion. This thyroid gland is made up of multiple follicles that is consisting of a single layer of the epithelial cells surrounding a lumen filled with the thyroglobulin. And this thyroglobulin is the storage form of the thyroid hormone. The thyroid function is controlled by the thyroid stimulating hormone, which is also known as the thyrotropin, TSH, which is being synthesized by the anterior pituitary, which in turn is being synthesized by the hypothalamic thyrotropin releasing hormone. So the TSH action is being mediated by the CAMP. So what initially happens is that the TSH action is mediated by the CAMP and leads to the stimulation of the iodide uptake by the thyroid gland through the iodide pump. Next is the oxidation of this iodide to iodine by a peroxidase enzyme, which is further followed by the iodination of the tyrosine residues present in the thyroglobulin. This leads to the formation of the monoiodotyrosine and diiodotyrosine. In the next step, it leads to the coupling or condensation of two diiodotyrosine residues to give T4 and one monoiodo and diiodotyrosine to give T3. And this condensation process is also facilitated by the peroxidase enzyme. And these hormones, the T3 and T4, are then released following the proteolytic cleavage of the thyroglobulin and hence by the endocytosis into the plasma. Most of the hormone, the T3 and T4, is bound to the thyroxine binding globulin in the plasma. The hormones must dissociate from the thyroxine binding globulin prior to entry into the cells. So within the cell, this T4 is enzymatically deiodinated to T3, which enters the nucleus and attaches to specific receptors. So we have already mentioned T3 is the most active form. That's why the T4 also gets converted to T3 to produce its action. So once within the nucleus, after attaching to the specific receptors, it causes the activation of these receptors, promoting the formation of RNA and subsequent protein synthesis, which is responsible for the effects of the T4. Now talking about the pharmacokinetics, both the T4 and T3 are absorbed after oral administration, whereas food, calcium preparations and aluminum containing antacids can decrease the absorption of T4. The main route of metabolism of the T4 is by deiodination, and T3 also undergoes sequential deiodination. The hormones are also metabolized via conjugation with the glucuronides and sulfates and get excreted into the bile. Now let's move on to the treatment of hypothyroidism and hyperthyroidism. So first is treatment of hypothyroidism. So what is hypothyroidism? It is the inadequate secretion of the thyroid hormones. This is mainly caused due to the autoimmune destruction of the thyroid gland and the peroxidase enzyme that is responsible for the oxidation and condensation of the thyroid hormones. And it is usually diagnosed by the elevated levels of TSH. Why is it so? Because when there is a reduced amount of the thyroid hormones, our body is trying to maintain the normal levels. That's why the hypothalamus releases the TRH and thereby releases the TSH from the anterior pituitary. So when there is a hypothyroidic condition, more amount of TSH is being produced to elevate the thyroid hormone levels. That is the reason why there is elevated TSH levels. The different hormonal preparations that is available for the treatment of hypothyroidism includes a levothyroxine, that is a T4 preparation, liothyronine T3 preparation, and a combination of T3 and T4, that is Liotrix. The levothyroxine is preferred over the T3 or T3-T4 combination for the treatment of hypothyroidism. It is better tolerated than the T3 preparations and has a longer half-life. Levothyroxine, since it is having a longer half-life, it is dosed once daily and steady state is achieved in 6 to 8 weeks. Toxicity is directly related to the T4 levels and manifests as nervousness, palpitations, tachycardia, heat intolerance and unexplained weight loss. So there is particular interactions with the cytochrome P450 enzyme inducers. Those drugs include the phenytoin, phenobarbital, rifampin. These drugs will increase the metabolism of these hormones and hence decrease the effectiveness of the thyroid hormonal preparation. Next, we're going to talk about the treatment of hyperthyroidism, that is thyrotoxicosis. The most common cause of the hyperthyroidism is the Graves' disease, which is an autoimmune disease that affects the thyroid. And in these situations, the TSH levels are reduced due to the negative feedback mechanism. That is, when the circulating thyroid hormone levels are really high, it causes the inhibition of the thyrotropin releasing hormone from the hypothalamus. As a result, it decreases the secretion of TSH. The main goal of therapy is to decrease the synthesis and or release of additional thyroid hormone. This can be accomplished by various mechanisms. So first is by the removal of part or all of the thyroid gland. This can be accomplished either surgically or by destruction of the gland with the radioactive iodine. So how is this possible? The mechanism of action of the radioactive iodine is physiological. That is, we know that iodine is the precursor of the thyroxine. The radioactive form of iodine is taken up by the iodide transporter of the thyroid the same way as the natural iodine and is similarly processed. So this beta particle will destroy the follicular cell and gradually leading to volume reduction and control of the thyrotoxicosis. So this is the method in which the radioactive iodine is useful in the treatment of hyperthyroidism. Now, the most patients become hypothyroid as a result of this radioactive iodine. As a result, may require the treatment with the levothyroxine. Next mechanism is via the inhibition of the thyroid hormone synthesis. So this is usually done by the thioamides. So the thioamides are the propyl thiouracil and methimazole, which get concentrated in the thyroid and inhibit both the oxidative processes required for iodination of thyrosyl groups and the condensation of the iodotyrosines to form T3 and T4. At the same time, the propyl thiouracil will also block the peripheral conversion of T4 to T3. So we had already mentioned that the T4 gets converted to T3, the most active form in the periphery within the cells. So that is being blocked by the propyl thiouracil. These drugs does not have any effect on the thyroglobulin already being stored in the gland. Therefore, what happens? The clinical effects of these drugs may be delayed until the thyroglobulin stores are depleted. The methimazole is preferred over the propyl thiouracil because it has a longer half-life, allowing for once daily dosing and with a lower incidence of adverse effects. However, the propyl thiouracil is recommended during the first trimester of pregnancy due to a greater risk of teratogenic effects with the methimazole. Other problems associated with the propyl thiouracil is that it can lead to hepatotoxicity and rarely agranulocytosis. So the next mechanism that is used in the treatment of hyperthyroidism is the blockade of the hormone release. So when a pharmacological dose of iodide is being administered orally, it will inhibit the iodination of tyrosines through an effect known as Wolff-Chaikoff effect, which will only last a few days. So what is this Wolff-Chaikoff effect? This is an autoregulatory phenomenon that inhibits the organification in the thyroid gland and formation of thyroid hormones inside the thyroid follicle and the release of thyroid hormones into the bloodstream. This becomes evident secondary to the elevated levels of the circulating iodide. So that means when we give a pharmacological dose of the iodide, what happens is that this will lead to a inhibition of the iodination of tyrosines. Most importantly, the iodide inhibits the release of thyroid hormones from thyroglobulin by mechanisms not yet understood. The iodide is employed to treat the thyroid storm or prior to surgery because it is decreasing the vascularity of the thyroid gland. And it is not useful for a long-term therapy because the thyroid ceases to respond to the drug after a few weeks. The other adverse effects associated with the iodide is that it leads to sore mouth and throat, swelling of the tongue or larynx, rashes, ulcerations of mucous membranes, and a metallic taste in the mouth. Last, we're going to talk about the thyroid storm. The thyroid storm presents with the extreme symptoms of the hyperthyroidism. And the treatment of the thyroid storm is the same as that of the hyperthyroidism, except that the drugs are given in much higher doses and more frequently. Beta blockers such as metoprolol or propranolol are effective in blunting the widespread sympathetic stimulation that occurs in the hyperthyroidism. So that is all about the treatment of hyperthyroidism and hypothyroidism. So now let's just summarize what we have learned in this video. In this video, we have talked about the synthesis and release of the thyroid hormone, the symptoms associated with the hypothyroidism and hyperthyroidism, treatment of hypothyroidism which includes levothyroxine, liothyronine and Liotrix, then the treatment of hyperthyroidism, that is by the removal of part or all of the thyroid, inhibition of thyroid hormone synthesis, and last by the blockade of hormone release. Then we talked about the thyroid storm and its treatment. So I hope that you have clearly understood regarding the thyroid hormones, its use and all. So if there's any doubt and comments, please do mail in us. Thank you.